well know. Don't get embarrassed. They are all about to sneeze. Look at it again. Okay. So allergic rhinitis has been defined as a symptomatic disorder of the nose induced by a IgE mediated inflammation after allergen exposure of the membranes lining the nasal cavities. This is to be remembered very importantly, and it usually entails a type 1 hypersensitivity reaction. So this can be one of your practical viva question, especially for the MS candidates. ARIA has classified allergic rhinitis into intermittent and persistent depending on the duration, and on the basis of severity into mild and moderate to severe. But remember, this classification applies to untreated patients, because in treated patients the whole pattern of symptoms and duration changes. So this is what you need to keep in mind in untreated patients. The diagnosis of allergic history, there is a detailed talk tomorrow by Dr. Prashant. I will not go into the details, but as like any other illness, history, clinical findings and investigations. History will be of the symptoms, the family history, occupational history, history of drug intake, and the history of trigger factors. And based on this, we classify the sufferers into two types. One is the sneezers and runners. The others are the blockers. Certain signs like the allergic salute is very conspicuous in these patients, and you can say spot diagnosis type feature. Also allergic shyness. And please remember, in India we also have allergic rhinoconjunctivitis, and this is what allergic conjunctivitis looks like. Now early detection is important and recommended by all the societies, because it is the first step for effective treatment. It helps identifying children who are at risk of developing asthma because of the allergic march. Now why we need to enable correct and optimal treatment is so that the avoid measures can be instituted. Appropriate symptomatic management can be given to the patients without making them dependent on either the oral or the inhaled agents. And in certain cases, immunotherapy can be instituted at the earliest, because this is the only modality which alters the natural course of the disease and can give a therapeutic cure. Pharmacotherapy will relieve only the symptoms. It will not do anything to alleviate the disease. So the recommendations for allergy diagnostic tests are present for both allergic rhinitis and asthma, because these are diseases which are part of the same spectrum but at different ends of the respiratory system, which is also known as one airway, one disease. So in allergic rhinitis it is indicated, also in asthma. Multitude of tests are available in vivo and in vitro. So the dilemma is which one to choose for which patient. Fortunately, all the societies had chosen this for us. So in vivo is the skin prick test, and the in vitro is the serum specific Ig, and not the total serum Ig that we are used to studying in our curriculum. The skin prick test is the gold standard for allergy diagnosis. It has been postulated by the World Allergy Organization, the IACI and the American. So there is unanimity and consensus all over the world. There are various advantages of the skin prick test, as has been elaborated in the slide. The results are quick, the authorities give it the first choice, better sensitivity and specificity. If your total serum Ig is high, there is no interference in the skin prick test. You can demonstrate to your patients also while doing the test. It resembles a physiological reaction, that is the wheal and the flare. The clinical correlation is excellent, cost is low, and the selection of antigens, well, you can choose, which is not possible in the serum specific test. But there are certain shortfalls or pitfalls, so it requires normal area skin for testing. So if there is any pigmentation disorder or if there is dermatographism, you cannot do the skin prick test, so it becomes a contraindication. In pregnant women you cannot do this, and also in patients who are on continuous antihistamines or who are on beta blockers, especially if they are asthmatic, you will not be able to do the skin prick test. So these become the contraindications for the skin prick test. The various advantages are mentioned in the slide. The prerequisites: you need to stop oral antihistaminics ideally 7 to 10 days. In practically we stop them at least for 5 days. Oral steroids need to be stopped if they have been given for any acute exacerbation, or if the patient is got nasal polyps. We do give oral steroids also sometimes. Intranasal and inhaled steroids are permitted because they don't get absorbed, so there will be no systemic reaction to this. Many of our patients are on Ayurvedic and homeopathy drugs. These also need to be stopped because they also alter the immune response. Nowadays, with the increased level of stress and anxiety in the society, many of our patients do take tricyclic antidepressants like amitriptyline or nortriptyline. So those also need to be stopped. Again, the minimum period prescribed is 3 days. Now for any procedure, documentation is important. So is for the skin prick test. You must have a proper questionnaire for the history taking. These are available on the internet. You need to document your examination and your nasal endoscopy findings. Consent form is a must for this procedure. For recording the skin prick test result, you must prepare a separate case sheet. You have to keep copies of all the documents with you, given that we are in the Consumer Protection Act and in this era of high vigilantism by the patients. Now, why this documentation is important? You can publish your results. So for your research work, you can plan your line of treatment, which is tailor-made for every patient, and in case any medico-legal issues arise, so you have a copy of the document which can save you from unnecessary compensation. Now, what do you require for a skin prick test? Most important is standardized allergen extracts. These are now available in India. Various companies are marketing them. One of them is with us today, Allvac. You need proper prick lancets. Now we use the 1 millimeter lancet. You need a marker pen, a calibrated ruler, tissue for wiping the solutions, the reporting sheets, and an emergency tray. You don't know which patient can throw a reaction and God forbid a anaphylactic. Although with the method that we use, I have not seen any anaphylaxis reaction in the last 20 years, but you have to be prepared for any dire emergency. The testing room ergonomics, so the room where you do the test must be designed in a particular way. It should be comfortable for the patient. Usually we do it on the forearm in the sitting position. You can also do the test by making the patient lie down on the forearm. This is to prevent vasovagal in certain patients. It should have a good lighting source so that you can see here. You can see in the right side picture the light is there so that you can see the reaction. The kit has to be there. It has to be stored in a refrigerator. We use a 1 millimeter tip, so it is minimally invasive and you get a proper result. No false positive results are present if you do the prick properly. Earlier we had a 3 millimeter tip which was giving lot of false positives. So we used to find 25 things the patient would be allergic to, and then we realized that the tip was the problem. So now the 1 millimeter allergy lancet tips are available freely. The site, earlier it used to be done on the back, but then it became a problem, especially with females. So the forearm is now used. In the males, we ask them to shave the forearm 2 days before. In the females, again they can use hair removal cream or waxing, but that also we advise 48 hours before. We mark the site where we are going to put the solutions on the forearm. Then we apply the drop of the antigen liquid, the extract that is available. These are purified saline extracts. The most important part of the test, the pricking. So as you can see in the slide, the 1 millimeter tip is being used. The direction of the prick is important. You cannot go vertically. You have to do it at an angle, at a 45-degree angle. And this is what the modified skin prick test is all about. So the tip of the lancet enters the epidermis and you gently pull it up. This is called the tenting phenomena. So you are still in the epidermis where the Langerhans cells or the mast cells are, and you introduce the antigen there to get the wheal and flare reaction. This is how the wheal reaction begins to look. So first we check with histamine and saline. If the histamine is coming positive, then we go ahead with the test. If the histamine is negative, that means the allergy is being suppressed for some reason. So you postpone the test by at least 3 to 5 days. Many times patient take OTC syrups, cough syrup like Honeytus and all, which suppress the reaction. They don't tell you. So you have to be very careful in your history when you see the patient and instruct them also that don't take any medicines without informing you, whichever kind of medicine. After the wheal reaction, we measure the reaction and document it. So anything that is less than 3 millimeters, we consider it as negative. Anything more than 3 millimeters, we consider it as positive. So saline can be either 0, 1 or maximum 2 millimeters. Histamine has to be at least 4 millimeters or more. Sometimes you get a pseudopodia-like reaction, which means an indicator that this is highly allergenic, that person is to that particular antigen. The reading can be documented either in millimeters or you can use the plus scale. The reporting has to be done. Everyone documents their own. This is by my friend Dr. Rupali. She does it in this way, where the wheal millimeter reaction and the remark is given so that the patient also understands the report with the conclusion. As you can see, even the histamine and saline reaction has been documented, and anything that is close to histamine or more is documented as positive. Thank you. So we'll go for the testing now. We have 2 counters. One counter Dr. Prashant will be there. One counter I will be there. We'll require 2 volunteers from you so that we can demonstrate on you how the test is done. And the time that will be taken will be around 10 to 15 minutes. So we will finish within the time that is allocated to us. The others can observe and ask questions.
Sir, a minute. I would like to call upon the chairmen of this session to felicitate Dr. Vikram Khanna sir, Dr. Mubarak Khan, Dr. Abhijit Mantri and Dr. Praveen Bhosle.